So my name is Emma. I know the last presenter was also named Emma. I presented the first week for you guys. So this is our third virtual round session for Motivate MD. We're happy to have all of you guys here with us tonight. Today we're going to talk about leukemias. You know, this obviously is in the realm of internal medicine, but obviously it's a hematology oncology kind of topic. So we're going to go through that. We're going to kind of keep it simple, you know, much like we did for the first session that we had for GI bleeds. I'm not trying to overwhelm you guys with information, really just try to enhance your knowledge at the level that you're at. If you guys have any questions at all at any time, I will be watching the chat box. And then Becca is also here with us tonight. She'll be watching it as well. So if you guys have any questions, there she is. She made an appearance. So if you have any questions, throw it in the chat. Feel free to talk out loud if you'd like to. Either way works for me. Okay. All right. So let's move on. So kind of like last time, we're going to really start with a case. We're going to go through a physical exam. We'll talk about the differential diagnosis, and then we'll kind of go into the assessment and plan, which will really transition us into the lesson on the pathology of the disease. And we'll be talking about leukemia, obviously, and a little bit in terms of different leukemias. If you missed it, we sent out a form in the chat box. That's going to be the same form that we've kind of sent out the last 2 times. It's for you to kind of take notes, to kind of practice writing in a SOAP note format. Then, you know, when you get to medical school and you start writing your notes, hopefully your future self will thank your past self for having done some of these activities to enhance your writing in the electronic medical record. All right. So here's the form, fairly simple. We're going to talk about, we're going to go through in a SOAP format. So SOAP, we'll do subjective, objective, assessment, and plan. And all these things should be fairly obvious for you. And as you kind of go along these sessions, our goal for you is that you start to really improve in terms of the information that you see fit, and including those items. All right. We are going to be talking about cancer. I like to start out with a joke, though. When I was making this PowerPoint, I thought it would be a little distasteful to start with a joke. So cancer is something that's very near and dear to my heart. I recognize some of the names out there, and I've probably told you this story. I originally got into medicine because of a personal experience with my dad. He had pancreatic cancer. So along the same lines kind of as last time, if you guys have been impacted by any of these cancers, why don't you mark them next to the cancer? And then we'll kind of get a good idea of, you know, our audience today and kind of see. All right, we have a prostate cancer. Okay, we have lung cancer, breast cancer, uterine cancer. Okay. Prostate, colon, melanoma. There's one at the top. I can't see because my bar is in the way. I'm not neglecting it, I promise. So as you can see, another breast cancer, pretty wide-reaching cancer. I think probably most of you know somebody or know of somebody of whom has been impacted by cancer. So hopefully this is a topic that everybody's kind of interested in learning. Leukemias and cancer certainly are very complex, as you guys know. So you know, I'm going to make it as simple for you guys as possible. And if you have any questions at all, feel free to reach out in the chat box or unmute yourself, either way. Okay, so like last time, we are going to go into the details about the case. So let's see here. Let me move around the chat box. So we have a 66-year-old male who presents to your clinic with a 2-month history of left upper quadrant abdominal pain and fatigue. He states that he used to walk his golden retriever 2.5 miles every morning, but as of lately, he can barely reach the end of his driveway without feeling shortness of breath and lightheadedness. He notes that he's lost 20 pounds over the last 2 months. It is not dieting or trying to lose weight. His spouse is present for the interview and states that he often soaks the bed sheets with the sweating each night, which led to her urging him to be seen, which you'll find out is often the case. It's always the spouse who makes them come in. He denies any illness, chest pain, nausea, vomiting, diarrhea, or headache. He's currently retired and worked for a nuclear power plant for 41 years. So take a last good look at all the bolded things. I was good to you guys again. I bolded the things that I consider important. So take a last good look at those things before we kind of go on here. So these are questions like last time, these are questions that we want to consider. So the first one are, what are the most concerning symptoms that this patient is presenting with today? So as I kind of indicated, I definitely want you guys to participate, throw something in the chat or unmute yourself, either way. But what are some of the symptoms of which this patient is presenting with that we want to be concerned about?
The unintentional weight loss is pretty concerning and might indicate malnutrition.
Good, perfect. I'm not sure who said that, but good point, great point. And then somebody put that Sabrina put that in the chat as well, unintentional weight loss. Exactly, and that's something that we certainly want to be concerned about. A number that we're kind of looking at in terms of that is at least 5% of your body weight in a period of about 6 months. That's what we're looking at. We're not talking about 5 pounds and over a month or 2 months. We're talking about a substantial amount of weight over a smaller period of time. What other symptoms are we concerned about? Good. Yeah, he used to be very active. He used to walk his golden retriever a lot, and now he's having lightheadedness. Exactly. What else? Any other symptoms that we should be concerned about for this guy? Shortness of breath. Good. Left upper quadrant abdominal pain. Good. Perfect. And if we're unexplained fatigue. Good. Exactly. Another word for that is malaise as well. We call it malaise. In medicine, you have to have 12 different names for one thing. So we'll expose you to those 12 billion different things over time. Okay, so good. You guys pinpointed a lot of those symptoms. I mean, you're exactly right. And we kind of talked about this a little bit, but throw your answer in the chat or unmute yourself. Is a 20-pound weight loss in 2 months, is that significant, or is that something we should kind of shrug off at this point?
That's significant.
It is significant, exactly. We didn't state or see what his initial weight was before, but 20 pounds in 2 months is significant. And if you remember in the kind of vignette for the question, it stated that he wasn't trying to diet or lose weight. That's always an important question to ask your patient if they have admitted or you see that they've lost weight. Are you dieting and exercising? Because if this guy lost 20 pounds in 2 months and he's doing a very rigorous exercise program, that's kind of another story essentially. Okay, so what parts of the history are particularly significant now? There was one big part that we want to pay attention to and kind of track in our mind. Did anyone catch that? Good. Working in a power plant. Yeah, work history, exactly. It's part of the social history. He worked in a nuclear power plant, and not only did he work in a nuclear power plant, but he worked there for a substantial amount of time. He worked there for about 41 years. So that's a while to kind of be exposed to different things on the job. All right, so good job on that one, guys. We're going to kind of move on with the physical exam here. So in terms of his vitals, he does have a fever. His temperature is at 101.3. He's tachycardic at 98. Respiratory rate is 17. His blood pressure is a little bit low at 107/77, and he's 93% on room air. That's what the RA means. He's ill appearing. He can't speak in full sentences, and he appears older than his stated age. He is tachycardic, as we kind of indicated from the vital signs themselves, but he has a regular rate and rhythm without murmurs, rubs, or gallops. His lungs are clear to auscultation. Splenomegaly is present, and he has diffuse tenderness to palpation, of which is worse in the left upper quadrant. He has cervical lymphadenopathy, so he has swollen lymph nodes in his anterior and his posterior chain. He has scattered petechiae and bruising noted throughout the skin, with remarkable skin pallor and poor capillary refill. So a couple questions I have for you guys. If you know, somebody writes in their note, the patient can't speak in full sentences, what does this mean? Is this you know, something that's significant? You know, what are they trying to get at something like this?
Might be some neurological problems.
Perhaps. Anybody else? What if I tell you or give you a clue about to look at his SpO2, to look at his oxygen? He's 93% on room air. Usually we want to look for, you know, a saturation, you know, perhaps from 95 and above. You know, most people fall in 98, 99, 100% saturation on room air. So what is, you know, not speaking in full sentences, what might that mean given his O2 saturation?
He may be short of breath.
Perfect. Yeah, good job. I think that was Linda. I saw your thing pop up when we started talking. Perfect. Good job. And that's exactly what that means. You know, a lot of times when people are short of breath, you know, they can't speak in full sentences. It sounds like they're panting. They have to kind of stop in the middle of their sentence, kind of take a breath. It might seem like they're really trying to swallow air because they're pretty short of breath. He appears older than his stated age, and he's ill appearing. So we know up front, you know, this guy is pretty sick. And then we know that he has splenomegaly. What organ is in the left upper quadrant? Here's you know, you see a little diagram, a little cartoon there illustrating, you know, the abdominal organs. You know, what are we kind of looking for in the left upper quadrant? Does anybody know that one?
Liver?
Close. Spleen. Yeah, good job. Good job. So the heart kind of does lie on that left side there, but that's more in the thoracic cavity. We're looking at the spleen, certainly. And that's exactly what splenomegaly means. It means a big spleen. You know, if we said hepatomegaly, that means a big liver. You know, same thing with your heart. If we said cardiomegaly, that means a big heart. So what we're looking at here is, you know, we're able to palpate the spleen on examination. So on this physical exam, we're saying that this patient has splenomegaly, and he's pretty tender to palpation when we try to palpate in that left upper quadrant. Other than this, his skin has petechiae on it. In the right upper image of the slide, you'll see kind of an example of petechiae. I remember when I was learning it, I was like, you know, what's the difference between petechiae and a bruise? But it's basically this little almost rupturing of a blood vessel, which is superficial. Purpura, which is kind of on the right side of that picture, it's a little bigger than petechiae. But you know, we certainly want to be concerned if people have, you know, if they're easily bruising, if they have petechiae, things like that. If you guys have any questions, go ahead and throw them in the chat at any point. Okay, so you'll learn whenever you get to medical school and beyond. A lot of people like to use these little skeletons for their results. So I put a little key in the upper left-hand corner. So we'll start with the one on the far left. So the patient's sodium is 137. So that's okay. The potassium's a little bit low. The chloride is at 101. We have a CO2 of 23, a BUN of 16, creatinine of 1.16, and a glucose of 99. Now, when we look at the CBC parameters, we see all red. It's never good when your lab reports come back in red. And it's certainly never good if we see a CBC with a white blood cell count that's 101. The upper limit of normal of the CBC count is around 10 at tops. CBC is complete blood count. So that is your lab work that shows your white blood cells, your red blood cells, your hemoglobin, your hematocrit, platelets. And then when we look at the red blood cell parameters, such as the hemoglobin and hematocrit, we see that the hemoglobin is low, the hematocrit is similarly low. And a little trick you can use for hemoglobin and hematocrit to kind of see if, make sure that it's correct, kind of check it in your head, is 3 times the hemoglobin should equal the hematocrit. So if you look at this, 10.1 times 3 is 30.3. So this is about right. So you kind of make that connection and make sure that what came out of the lab was good results. Then the platelets are at 611, which is certainly high. That's a high platelet count. Other labs that we're afforded is calcium. Calcium's a little bit high. Uric acid is high. LDH is very high, and vitamin B12 is high. Other things that we see are a red blood cell count of 3.91. That's a little bit low, and we see an MCV, a mean corpuscular volume, which is kind of the size of the red blood cells. That's low. That should be around 80 to 100 approximately. And the reference ranges always change based on the lab for sure. So there are our labs. So the next question I have for you guys, and let me see if okay. So the next question I have for you guys here is, and before I ask you the question, up in the top of the slide, you'll see a mechanism, an example of how to make a blood slide. This may seem kind of mundane to you as medical school or medical students, pre-medical students. I got my early start working in the lab doing this very technique. So looking under microscopes and making blood slides is something that interests me and still does. So how you make this blood slide essentially is you put a drop of blood on the slide, and as this gloved hand is indicating, you pull it back, and then you basically smear the blood across the slide. And it is a little bit harder than it looks. You want to have a good feathered edge. And when I say feathered edge, it really does look like a feather. And then after the blood kind of dries on the slide, then we stain it. We stain it with a right Giemsa stain. And, then we're able to look at it underneath the microscope. And that's really what comes out of that's basically what this image is on the slide. So similar to how we did, the first 2 questions when we annotated the slide, I would like you guys to indicate to me, is this a normal or is this an abnormal blood smear? Take a few seconds to answer that. All right, we have one answer in there. Good. People are answering in the chat as well. Perfect. Good. You guys are intuitive, I think, because I feel like you know, because we're talking about leukemias, this is probably not a normal blood smear. And you guys are all absolutely right. This is not a normal blood smear. We see a lot of immature cells here. You know, there are some normal cells. We see a few basophils in, you know, this slide alone. You know, in the upper left-hand corner, hopefully you can see my cursor. You can see a basophil there, as well as you can see a basophil on the far right side of the slide. You know, by percentage, if you were to count 100 cells, you should probably only find, you know, maybe 1 or 2 basophils. And in this slide alone, this, you know, part of this slide that we're looking at, this picture of the slide, we see 3 basophils. We do see some mature right here in the middle. We do see a mature neutrophil, but there are kind of these immature cells that look kind of ugly to us. So, you know, you guys are right. This is an abnormal blood smear. So, you know, we definitely want to kind of have our antenna up and kind of look into this, you know, what's going on here. Other than this, we do see some immature myeloid cell lines. We see, you know, maybe a band cell here. You know, maybe this is a myelocyte here, maybe a metamyelocyte here. But you know, this is certainly an immature cell. So and we'll talk, if you guys are like, oh my God, I don't know any of these cells, that's okay. We're gonna kind of go through each of them a little bit later as well. And it takes a lot of practice how to look at these things. I used to have a professor when I was in lab tech school long ago, many moons ago. He used to say that looking under the microscope at this stuff is like bird watching. And he literally would put birds on our exams and give us extra credit if we were able to like find these birds. And then I like found myself studying the birds more than the cells, and I was like, wait, this is backwards. I can't keep doing this. So, but anyway, I always remembered that. But, okay, so things that we want to consider for our differential diagnosis. You know, certainly we want to have leukemia at the top of our differential diagnosis. We know that there's a lot of abnormal cells in our differential, and you know, the things that we want to consider are chronic versus acute leukemia and myeloid versus lymphoid leukemia. And we're going to talk about those a little bit more down the road. So don't be too alarmed if you're not sure what those terms mean right this second. The second thing that we want to consider is a leukemoid reaction. And essentially what that means is it's a fancy way of saying basically a increase in your white blood cells, your blood cells that fight infection as a result of an infection, being exposed to, you know, a bacteria, a virus, a parasite, etc. So that could certainly be the case here. We don't know that that's not the case, though there is part of his history that, you know, may suggest otherwise. The other part, you know, that we want to consider, put in our differential diagnosis is lymphoma. We want to consider whether this is a lymphoma, a cancer of the lymph nodes. And then the other thing, due to having his lymph nodes swollen, we definitely want to consider something like infectious mononucleosis, which is caused by the Epstein-Barr virus, which is EBV, okay? All right, so let's talk a little bit about our assessment and plan. What ideas do you have for you know, what we should do for this patient at this point? What are you guys thinking? What are kind of our next steps? What tests should we order? You know, who should we call? Things like this. What should we do at this point? Okay. And we have a CBC, we have WBC. If you guys remember, we did have those a few slides ago. We had a very high white blood cell count. If you guys remember here, this 101, that's our white blood cell count. We have that. We know that we have a very, very high white blood cell count. And our CBC is right here. We have a low hemoglobin, we have a low hematocrit, and we have a high platelet. Put on fluids, yeah. I mean, that's never a bad idea. When in doubt, say fluids. It's never a bad thing to give this guy fluids, especially if he's anemic. So yeah, good job, Cameron. Any other ideas, anybody? A&A? Okay, are assumably someone thinks this might be some sort of rheumatologic disorder. Diagnostic imaging, okay. Sabrina, what kind of diagnostic imaging do you want to get? And does anybody else have any kind of test that you might, recommend for this patient? So if we're thinking this is a leukemia, think about, we could consider that certainly an MRI or a CT. If we're thinking this is a leukemia, where do we know that white blood cells and red blood cells are produced? What do we kind of want to take a look at, essentially? Bone marrow, good job. Yeah, bone marrow, exactly. You guys are right on point. And if we got an X-ray, we might even show we could even see some hematopoiesis in the bone. So you guys aren't very far off at all. Your intuition is correct. Perfect, bone marrow. We certainly want to look at that. So that's what our first assessment is. We know that 3 things are going on here. We know that he has a leukocytosis, and when you hear the term cytosis, that means the count is increased. So for instance, we have a leukocytosis and we have a thrombocytosis. Thrombo meaning platelets, cytosis meaning it's increased. Leuko meaning white blood cells, and cytosis meaning increase. So our white blood cells and our platelets are increased, and we have an anemia as demonstrated by the low hemoglobin and the low hematocrit. Okay, as you guys kind of indicated, we want to look at the bone marrow. You guys are exactly right. We have kind of evidence right now to say, there's something going on with this patient, and we want to find out whether it is a leukemoid reaction because of, because of an infection, or if this is a true leukemia. So the next test that we're going to do, and there's no way I would have expected you guys to pick FISH or PCR out of a bunch. So I'll tell you about it a little bit here. And what this is basically, and there's an image kind of at the bottom, at the upper right-hand corner, and this kind of demonstrates the concept of FISH. And there's a picture as well on here. And basically, what FISH is you're using a fluorescent technique. It's fluorescence in situ hybridization. So it's, like a $100 word to say, basically what we're doing is taking a probe and we're trying to match up a specific sequence of DNA to see if there's a translocation. So that's what we're looking for in, specific leukemias and, specific genetic alterations. And we can also do a very similar technique with PCR and kind of look at the DNA as well. So given our peripheral blood smear, given the type of cells that we saw, and really if we go back to kind of our peripheral blood smear here, we know that we have a lot of cells that, some are immature, but some are certainly mature. So we know that this may in fact be, maybe a chronic leukemia, and we'll talk a little bit about chronic down the line too. So by this, due to the basophilia, we're kind of suspicious that this might be a chronic myeloid leukemia. Chronic meaning there's a lot of mature cells in the blood. Also, there's not, a lot of blasts that we can see. Blasts meaning immature, nearly stem cells in the blood. And then the other part of it is myeloid, meaning we see a lot of, myeloid versus lymphoid. We see a lot of myeloid cells that give kind of rise to cells such as basophils, neutrophils, and eosinophils. So And then I kind of skipped over this initially, but here's a cell here, and this is a blast cell on this slide here, on this differential diagnosis slide. And this is what I was talking about, those immature cells where what you see basically is a big nucleus to cytoplasmic ratio. You see, you know, the nucleus kind of fills up the whole cell. You kind of see this immature chromatin inside of the nucleus where it's kind of lacy. You've seen nucleolus, very prominent nucleoli here, one kind of at the bottom and one, you know, at the top, really. And it's kind of lacy, it's very immature. And then as we see the cells kind of progress, we start to see the chromatin becoming more clumpy. And you'll see an example of that towards the end. But all of that to say is we're kind of suspicious that this might be a chronic myeloid leukemia. And so what we're going to look for is this classic translocation. And the way that we kind of write this is a T, and then in parentheses, we have 9 and then 22. So what it means is basically, you know, as the image in the upper right-hand corner is demonstrating, is part of one chromosome and another, 9 and 22, have essentially traded parts. And this ends up being a translocation. The BCR-ABL gene fusion is what's formed. That gene is a tyrosine kinase that leads to uncontrolled cell growth, hence the leukemia, the very high white count that we're seeing, you know, the very high platelet count, lots of cells, but lots of dysfunctional cells. So that's what we're going to look for here. We have, you know, sort of suspicion from the peripheral blood smear, from the high white cell count, from this patient's exposure, having been exposed to radiation in the past. We're thinking, you know, based on his age, also he's 66 years old. We're thinking, you know, maybe this is a chronic myeloid leukemia. So let's look for this Philadelphia chromosome. This was actually named Philadelphia because it was discovered in Philadelphia by 2 different scientists in Philadelphia, in case you're curious. We can certainly give hydroxyurea due to these increased white blood cell counts that's going on right now, and to kind of, you know, help symptomatically, and also, you know, reduce these WBC counts. Because we're certainly suspecting that this may be a leukemia at this point. Other things that we want to consider, certainly due to these, as we kind of go back to our details about the other labs, we knew that the uric acid was high, we knew that the calcium was high, we knew that the LDH was high, and the B12 was also high too. And I was kind of stating that to kind of prepare you in order to ask you another question, of which is, why might those parameters all be high? Obviously, we know why the white count's high, but why do we think the uric acid and the calcium and the lactate dehydrogenase and the vitamin B12, why do we think those are high? What might be causing something like that at this point in the context of a leukemia? Who has any ideas for that?
Could the blood not be filtering correctly as a result of size change?
So you guys are on a good kind of path. Think about the cells here. I mentioned something before about there being a lot of cells involved here in this leukemia. You know, obviously that's the case given a white blood cell count of 101. That's, you know, very, very high. In a chronic myeloid leukemia, it's often greater than 25, but, you know, sometimes even higher than 100, and ours was at 101. So think about those cells, you know, what's happening, you know, as there's a lot of cells, you know, white blood cells don't live forever, ever. So what's going to happen, you know, when those cells start to die off? Does anybody have any ideas in terms of that? That's the best hint I'm going to give you without giving it away completely.
Can you actually repeat that again?
Yeah, absolutely. So basically what's happening here, we have a very, very high white count. The bone marrow is really due to this BCR-ABL gene fusion. There's a tyrosine kinase that is resulting in this uncontrolled cell growth, which is resulting in this cancer. So cells are really turning over very rapidly, is what's happening. So why is the lactate high? Why is the calcium high? Why is the uric acid high? Why are all these things high? What's going on here? What can we attribute this to?
And you're just talking about like uncontrolled cell growth?
Exactly, yes.
So then that would just be like a lack of apoptosis from like G1 to G2 or like something like that.
Right, so you're on the right path as well. And Zena, exactly right. Increased catabolism. It's true. So when you have that many cells, you have an increased white count, but you have to remember that these are cancer cells. You're more prone to infection, you're more prone to bleeding, you're more prone to, a lot of things. You have increased platelets, but those aren't plugging up the bleeding because they're dysfunctional. In the same way, they're not functioning. So the cells are kind of turning over rapidly, and the contents of those cells are becoming increased in the blood. So that's, uric acid, that's calcium, vitamin B12, among other things. They're becoming high in the blood. So that's why these cells are dying, almost as quickly as they're being produced from the bone marrow, and they're turning over very rapidly. So on that note, something that we may want to consider is giving this patient allopurinol or rasburicase. And those are two drugs of which can help with tumor lysis syndrome so that we don't get renal failure due to this increased amount of uric acid being filtered by the kidneys. Similarly, we want to avoid this patient having things like gout from an increased buildup of uric acid. Along the same lines, once we have, a confirmed diagnosis of chronic myeloid leukemia, CML, we might give a tyrosine kinase inhibitor. Basically this drug, imatinib, inhibits this BCR-ABL gene fusion that causes this uncontrolled cell growth. Then another thing that we can consider is an allogenic stem cell transplant. And the people that we look for here are often brothers or sisters to see if they're a match, because they're often kind of the closest match. And kind of a shout out to some of these programs out there. I don't know if you guys have done it yourself. You can sign up to be a bone marrow donor. I signed up a long time ago with a program back in college, which seems like forever ago, but I haven't gotten called just yet, but there's a very non-invasive way to donate bone marrow now, so you might look into that. You could certainly help save somebody's life one day. Okay, so hypoxia. This patient's also hypoxic. Somebody remind me, how do we know this patient's hypoxic? What signs did we kind of have that indicated that this patient, good. Low OT, perfect. And what else? What did we see from his physical exam? Shortness of breath, good, perfect. Yeah, he was speaking in short sentences, good. So we want to start this guy on oxygen. We want to give him some O2, and we want to monitor his saturations. If he is not doing well on 2 liters of O2, we want to kind of monitor at this. And if he's not doing well, we might consider intubating him if he's not able to protect his airway. Okay. The next thing is hypotension. And what do we do for hypotension? If he's anemic and he has a low blood pressure, what do we give him? Somebody said this before. Fluids, there he is. There's Cameron. Yeah, exactly. You're exactly right. And came in clutch. Fluids, we're gonna give him fluids. Does anybody know, is there any EMTs out there or anybody that knows what type of fluids we would consider giving this person? Or anyone that's scribing experience either, being around fluids for a long time.
Would you just want to do regular sodium chloride?
Yeah, you certainly can. Another thing you can always do is lactated ringers. It has an increased concentration, essentially. It can help him increase his blood pressure a little bit quicker. But you guys are exactly right. And you know, do we want to give this patient blood? Is that something we want to consider also? He had a hemoglobin of 10.1. Is he at the point where we want to transfuse him just yet? No, good. Linda said no. Why, Linda? Do you know? If it was a guess, you're on point. Why don't we want to transfuse him just yet? It was a guess. Okay. Well, it was a good guess, and you had a 50-50 chance of getting it right. So, you know, good job. Good job at that point. But you're right. You're absolutely right. We don't want to transfuse him at this point just yet. The kind of barrier that we want to consider and we want to look at is 7 grams per deciliter for the hemoglobin to transfuse someone. He's not there just yet. So we want to see, you know, how he's going to respond to these things, and then maybe consider transfusing him down the line. Okay. And that's what I wrote at the bottom, IV fluids. NS is normal saline, LR is lactated ringer. So we can consider either of those things. Let's kind of jumping through this. Okay. All right, so we're going to talk a little bit now about the pathology of leukemia. You guys did a good job sort of answering the questions that came along with this. This is a very challenging topic. I know that a lot of people have trouble with it in medical school as well. I was very fortunate to have learned this also in lab tech school, and very fortunate to have worked at Johns Hopkins for 2 years, where I saw a lot of different cancers, you know, sort of come across the microscope, looking at peripheral blood smears and seeing and being exposed to this pretty frequently when I worked in hematology. So we're going to talk a little bit about leukemia. As I kind of indicated before, there's 2 kind of branches of leukemias. The 2 that we want to kind of talk about are chronic leukemia and acute leukemia. And this is a little bit different than kind of what you would think traditionally. Traditionally, what we think of is, okay, acute, it's happening, you know, right now. It just happened. Chronic, it's been there for a long time. It's a little bit different for leukemias, and as you kind of know, there's always exceptions to every rule. Leukemia is that exception to that kind of time frame in terms of classifying it. So for chronic leukemias, what we are kind of defining it as is mature, sort of differentiated cells. As we kind of saw in that blood smear before, we saw a lot of mature cells. We didn't see a lot of blast cells, those immature cells. There's a lot of them, and they're in excess. So the 2 kind of chronic leukemias that you know I have written as an example are CML, chronic myeloid leukemia, and chronic lymphoid leukemia. And the difference between those is lymphoid versus myeloid. And I'll kind of show you a graphic in the upcoming slides that differentiates what's, you know, the difference between lymphoid versus myeloid. Whereas, you know, lymphoid is obviously lymphocytes. Myeloid is kind of those granulocytes that are going to give rise to those granulocytes like basophils, eosinophils, neutrophils, okay, and monocytes. Okay. The next, and then we have a little graphic here. Something very unique for CLL is something that we see, and they're called smudge cells. And don't I love when something's called something very appropriate, and you know, they look like they're smudged and they're called smudge cells. So you know, kudos to whoever kind of named this that, brilliant. And also they look exactly like they're smudged. Another word for it, for someone who wanted to make it complicated, sometimes it's called basket cells. And I'm not really sure why, I never figured that out, but they're also called basket cells, in case you hear that in the future. And you'll see in CLL, in this picture that we have here of this peripheral blood smear, obviously we made that smear, we stained it, and then now we're looking at it under the microscope. And what we see here is a lot of lymphocytes. These are mature lymphocytes here. The way I remember it for lymphocytes here, they look mature, and in CLL, they kind of look like soccer balls to me. And that might be because I played soccer for many years, I coached soccer for many years. So maybe that's just my mind trying to make a connection. I don't know if anyone else is a soccer person out there, but I see soccer balls, but make it whatever you kind of remember. So that's CLL there. And then the other thing, that we want to consider is acute leukemias. And acute meaning these are immature cells, these are blasts, as I kind of showed you before. They kind of have that lacy chromatin. You can see those nucleoli. You see a high N to C ratio, meaning nucleus to cytoplasmic ratio, meaning the nucleus kind of fills up that whole cell. It kind of is hogging the cell because it hasn't matured just yet. The examples of these are acute myeloid leukemia and acute lymphoid leukemia. And then to make it even more complicated, acute lymphoid leukemia can be classified into T cell and B cell. And then, when we're talking about the risk factors of, or the etiology of, these cancers, these leukemias, the things that we want to talk about in terms of exposures are solvents and radiation. Radiation is a big one, and we're talking about sort of ionized radiation. The thing that we certainly were exposed to with this case is, this guy having worked in a nuclear power plant for 41 years. So he was exposed to prior radiation, for a long period of time. So that was certainly one of his risk factors. Then other things that we want to consider are, chemotherapy, being exposed to prior radiation, such as being irradiated for other cancers, for instance, and then other genetic anomalies such as trisomy 21, so Down syndrome, or myelodysplastic syndrome, that's MDS, or sort of a family history of any of these genetic anomalies as well. Okay, treatment for cancer can cause cancer. Yes, paradoxically it can, and that's kind of what is kind of a downplay for it. So sometimes, radiation has gotten better to the point where it's very specific to what we're radiating now. But sometimes we talk about that in people who were radiated for cancers a long time ago when we weren't so specific in where we were radiating. But yes, radiating for cancer and treatment for cancer can cause cancer. Unfortunately, yes. Okay, if there's any other questions, just throw them in the chat. Okay, so this was the famous little complicated pictograph that I wanted to show you guys. So let's start at the top, and we'll kind of take it very simply going down the line here. And if you guys have any questions, let me know. This can be kind of tedious. And so really what we're looking at here is up at the top, we see a stem cell, and we know that stem cells are hematopoietic stem cells. That's what this is right here. And they can sort of have two fates, really a few fates. So they can kind of take this route and go to become, a myeloid lineage, which, as we kind of talked about, that's really what we're talking about today. We're talking about CML. We're talking about here. So we're talking about oh my God, that was a horrible L or M, CML. So this is, and that's what the M means here is myeloid. So when this hematopoietic stem cell kind of takes this left turn and goes down this route, it's going to the myeloid lineage. And so here's a myeloblast. It's an immature kind of myeloid cell. Then it kind of matures, and as it goes along its sort of progression, it starts to mature, and it becomes these sort of granulocytes. That's what we call these cells. So here's a basophil. It has this very sort of purple granules. I kind of pointed those out to you. Hopefully you remember those. And we should only see about like 1 to 2% of these. So these are very low. And as you remember, we saw a lot of those in that first slide, and one part of the slide. So there was a lot of basophils there. We also see eosinophils. We see those high in allergies. We see them high in parasitic infections. More so allergies now that, you know, here in the United States, we don't see a lot of parasitic infections unless you're drinking out of like the Rio Grande where there is Giardia. But other than that, we are also talking about neutrophils. These are a granulocyte of which is a phagocyte. It kind of engulfs, you know, bacteria and invaders in the blood. And then we have our monocyte here. And then sort of the hematopoietic stem cell can kind of take another turn and become a megakaryocyte, which gives rise to all these platelets, all these little guys that kind of help with forming that platelet plug to stop bleeding. And as you remember, our platelet count was 611. It was very high, but these guys are dysfunctional in cancer. So they're not working, you know, like they should be. And then here's our red blood cell lineage as it kind of progresses down this way. And then the other part that we kind of want to compare the myeloid to is the lymphoid. So this is where we talk about, you know, CLL, chronic lymphocytic leukemia, or AML, acute lymphocytic leukemia, ALL, and where this L is for lymphoid. We're talking about these lymphoid cells now. And then here's that mature lymphocyte, as we kind of saw in CLL, where I kind of talked about a soccer ball. I still think it looks like a soccer ball. But hopefully this kind of helps you to have a good graphic representation. As you kind of know, there's like 1,000 pictures in this presentation so far. And I don't think there's any better way to kind of learn this than from pictures. So I will clear that and we'll kind of go on. I have, so this is kind of a cartoon about this. So as we talked about, the chromosome 9 and the chromosome 22, the ABL from chromosome 9 and the BCR from chromosome 22, they kind of translocate. It's a balanced reciprocal translocation, which means the same parts kind of translocate, which leads to this Philadelphia chromosome. So they put a little Philadelphia cheesesteak there to kind of show you that, which leads to the tyrosine kinase and the uncontrolled cell growth. So that's kind of a cartoon about it. But what I have for you now that you guys know, you know, hopefully what a blast is versus what a mature cell looks like. Obviously, when we're talking about chronic, those are going to be mature cells, and acute is going to be more of immature blast cells. So I have a question for you guys. I'm going to start the polling for you. So you should be able to see a poll at this point. So let me know, is this I'll give you about a minute or so. Is this a acute or chronic leukemia? So you can kind of answer what you think so far. So I'll give you about 30 more seconds. Okay, so far so good. Okay. Okay. So I'm going to share these with you. You should be able to see them. So the majority of you said acute. Can somebody tell me why you chose acute if you chose acute? Or even somebody who chose chronic, why do you think this is chronic? I want to hear from you guys. What are you thinking? What are you seeing? Yeah, good, Trish. I think that's, I assume that's your name from your username. Hopefully that is it. So yes, exactly. The nucleus to cytoplasmic ratio. Well, perfect. I got your name right. Exactly. There's a very high N to C ratio. There's those very big cells. And what you can kind of do for something like this is use the red blood cells next to that white blood cell as a measuring stick to kind of say, okay, you know, this cell is big. It's pretty large. So exactly. What else? What else kind of tells us that this may be an acute leukemia? There was another thing that I kind of mentioned to you, whether, and both kind of have to do with the nucleus itself, other than the nucleus to cytoplasmic ratio. Lacey, chromatin, good job. I'm glad you remembered that. Perfect. The chromatin can tell us that as well. It's kind of lacy. It's not very clumped. What else? There's one other thing that I'm looking for, and you can see it very, very well in this slide. And I love this slide because it shows lots of blasts here. Every one of these cells is a blast cell, an immature cell. What do we see in the nucleus? We see kind of obviously that lacy chromatin, but what are these kind of circles that we see in the nucleus of these blast cells? What are those? I know you guys know that from biology. Hopefully you've taken biology at this point where you had to learn all the cell parts and all of that, the mitochondria and all of those different things. Close, central, no, nucleolus, perfect. We can see those nucleoli here, and that tells us these cells are certainly immature cells. This tells us that this is probably a acute leukemia, and you know, it's hard to tell from this, you know, specifically. This could certainly be an AML, meaning an acute myeloid leukemia, or acute lymphoid leukemia. So good job with this one, guys. Does anybody have a question? Anybody from the chronic side? If you chose chronic and you stand by it, let me know. What are you thinking? Why did you think chronic? Feel free to speak up.
Maybe I misheard you, but what did you say that younger blast cells or immature blast cells are indicative of acute leukemia?
Exactly. So
okay.
acute,
I misheard you.
yeah. So, and I can certainly go back to that slide too if you're kind of a visual learner. Here it is. So immature cells and blast cells are acute leukemia. So you might have just got it backwards in your head. So, and don't worry, I have a couple more questions for you guys to really practice this and nail it down. So let's go on to one more, or actually I have two more for you here. So let me start this poll for you. I'll give you guys a few more seconds here. I know we have 8 people in, we have a few more people total. I'll give you guys a few more seconds to lock in your guess here. Okay, let's see. All right, so the majority of you guys said chronic for this one. And somebody who said chronic or somebody who said acute, tell me what you think about this one. Why did you say, you know, why did you say chronic or why did you say acute for this? What kind of cell are we looking at here? This one that I just circled right now. What kind of cell is that? Your guys are close to basophil. With basophil, we kind of see granules, and I'll show you another basophil here in a second. But this one is a lymphocyte. And it's kind of the soccer ball that I was telling you. And here, all I see is soccer balls. So these are all lymphocytes. They're all kind of the same size. As you can kind of see, these guys are the same size as this, red blood cell here. And that's how you can kind of tell these aren't blasts. These are small, kind of compact cells. So these are all lymphocytes here. And while I'm sort of on the thought, let's go back a couple slides here. Here's a basophil here in the bottom left-hand corner down here. You can kind of see those granules, whereas a lymphocyte, you just see that kind of nucleus, okay? Why is this a chronic? Why is this acute? What are you guys thinking? What makes this chronic or acute? Somebody who said chronic, let me know your thoughts for this. So what do we know by definition? We know that chronic means what? We know that we have a lot of lymphocytes here. So why does that tell us that this is a chronic leukemia? Mature lymphocytes, perfect, Linda. You hit the nail on the head, and you're absolutely right. Chronic means mature differentiated cells. Acute, we're kind of looking more for blasts. So you guys are right. And I have one more question before we move on to the next one. What is this cell right here? I know I told you about it before. What is this one up here?
Basket cell?
Exactly, yeah. What's the other word for it that's appropriately named? I know you guys, what does it look like?
Oh,
Yeah,
smudge cell.
Yeah, I'll even accept that. It's absolutely right. It's a smudge cell, but I think if you said smear cell to your attending or to a pathologist, they'll be like, yeah, you're not wrong. It's, it is smeared. And that's for CLL, smudge cells are indicative of that because you have all of these, you have a ton of cells there, and very, you have a lot of mature cells, but they're dysfunctional. So when you make that smear, they kind of smudge on the slide, okay? I have one more for you guys here before we go on. I hope that all of you guys get this one correct. I hope we've kind of nailed this point home here. So let me relaunch this here. I will give you about 30 seconds for this one. I have faith in you guys. I know you can get this one. We have a couple of you guys in there so far. And don't be discouraged if you're getting any questions wrong or anything. That's only part of learning, and this is a pretty challenging topic in general. So you'll be prepared when you learn about this in school, hopefully, or at least be exposed to it. All right, I'll give you guys a few more seconds. We have a few of you guys in there. All right. Anybody else need to answer? Throw your answer in. All right. Okay. So the vast majority of you guys said acute, and this was kind of this was a challenging one, and I debated taking this slide specifically out because it's a hard one, because this is CML, but this is a different kind of presentation of CML than we're used to, than the one that we kind of saw before. There are kind of immature cells here, and there are blast cells, which would indicate to you that this is an acute presentation, but this is CML in kind of what we call a blast crisis. So it kind of converted to something else. So there is a lot of mature cells here. So really, everybody was correct with this one. So I'll say, I won't be like that person that says, actually all of you are wrong. Technically all of you are right, really, because this is CML, which is kind of converted to a blast crisis. So it's really kind of almost both of those presentations. So good job with that. You guys recognized it looked like both of those presentations. Here, I think this is kind of a blast here. That was a terrible B. Let me try to fix it. Okay, there's a blast. Here's kind of a neutrophil here. Here's neutrophils all around here. And this is maybe a monocyte that's kind of compact. This is not a great slide. You can kind of see the staining here is not great, but we'll take what we can get. Okay. We're kind of wrapping up here. We're going to talk about, the pathology itself. And really, we'll start by talking about the diagnosis and evaluation. What we're looking for here was that initial test. We looked for the CBC, the complete blood count with the peripheral blood smear. Then we kind of went into the bone marrow biopsy and we did flow cytometry or FISH. We talked about FISH, which is fluorescent in situ hybridization, where we kind of get that probe and kind of match it up in order to find that translocation. And then I have two images for you in the top of the slide that talks about flow cytometry. So really what happens with flow cytometry is you put the sample in to a detector or to an aperture. It kind of goes single file through this line, and then a laser beam is pointed at it, and a detector kind of, acutely really separates all these things and says, okay, this is this, this is this, this is this. So you can kind of get a good indication of what kind of population you're looking at. Similarly, you can kind of detect these cluster of differentiation cells, or markers rather. That's what CD means. So we can look at all these things here in the bottom or the top right-hand corner, where, if we see certain cluster of differentiation cells or markers, I keep saying that, then that might indicate to us that we're looking at a certain cell or a certain cell population, which can indicate a certain cancer. So that's kind of, a brief part on that, because it can get pretty complicated. Then, when we talk about the treatment, we want to talk about imatinib. We talked about how that's a tyrosine kinase inhibitor here, and we can talk about getting a sibling involved to do a allogeneic stem cell transplant. Then for AML, meaning acute myeloid leukemia and acute lymphoid leukemia, the treatment for that is chemotherapy. And then APL, which is acute promyelocytic leukemia, and you're probably like, okay, where did the P come from? It's basically just a kind of variant of acute myeloid leukemia. So you guys are probably all going cross-eyed by now, and I'm trying to keep it as simple as possible, but this is treated with all trans-retinoic acid. Okay. All right, so in the bottom left-hand corner, what we see is we see here a peripheral blood smear, and then here we kind of see a bone marrow biopsy. And what we're seeing kind of here, 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 and here, and down here. Oh, I made a mess. And over here as well, what we're seeing is really adipocytes, because the bone marrow is filled with fat cells. So we see here this bone marrow is full of a lot of cells, and even here we see a lot of cells here in this bone marrow representation as well. Okay. All right, so let's see here. And that is all I have for this. I hope this was helpful for you guys. I hope it was a valuable use of your time here. If you guys have any questions, feel free to unmute yourself. Feel free to type anything in the chat. I hope it was clear for you guys and not too sort of convoluted or anything, because this can certainly be a challenging topic to learn, at any level. But the more work you put into it, the harder you work at it, the more you'll understand it. So let me know if you guys have any questions. Thank you all for coming. It was a pleasure, and I always enjoy this and talking to you guys. You guys are all very welcome. Our next session is in a couple of weeks. My colleague, of whom is also named Emma, will be presenting, and she will be a valuable asset to you guys. She's very close to her residency. She'll have lots of information for you guys. Let me know if you guys have any questions. I'll stick around for a few minutes to kind of answer any questions that you guys have. And other than that, have a good night. Enjoy the rest of your week and your weekend.
Hey Emma, I have a question.
Yeah, absolutely.
So I got like all of the slides wrong, and
Okay.
I was wondering, for histology and hematology, like what's the best way to like study?
Okay. Yeah. So just in general for each of them?
Yeah, just in general.
Yeah, so the more pictures that you can see and the more I think that you can force yourself to really look at the pictures, the more you're really going to learn, I think. So that's really what's the sort of thing that helped me is repetition. You can say in theory, this is what this looks like, but I think it's identifying it over and over. And that's really what's going to help you, I think, in histology. It's a very visual subject. Even anatomy is a very visual subject. So kind of seeing those pictures, there's a lot of great sites online that offer, images. They publish their stuff. A few of the resources that I used even were, I think I used University of Minnesota and stuff like that. They publish things like this, and people publish these slides and their histology slides that really show they show, what it really looks like underneath the microscope. Because as you know, sometimes those cartoons are, they're too perfect and they sometimes don't represent the cells, completely. So I would say repetition for sure. And don't get too overwhelmed, when you get to medical school or when you take a histology class. It can be overwhelming at first, but some of this is just like learning a new language. You kind of just have to immerse yourself in it. Does that kind of help you?
Yes, I do. Thank you.